First of all, I'd like to say thank you for everybody showing up. We want to acknowledge our indebtedness to you folks in Canada. This program has a lot of its inspiration that comes out of the work that both Dr. Cornelius and Dr. Iglesias have done. And they're really sort of the parents of rural medical generalism, at least as far as its academic chops go. So that's kind of my entry into this. I'm part of the procedural folks that train our fellow. I have my partner and a guy that I helped trained that does a lot of this, Dr. Jensen. So hi to everybody, and I'm letting Joel take over. Musical chairs again.
Okay. So the idea that we can do a fellowship in rural Iowa is just based on the premise that learning can occur any place if we've got a learner, a teacher, and a learning opportunity. And I think I don't have to sell anybody on that idea, but where we're doing this, I think makes us somewhat unique. We are 1.5 hours from anywhere. Frontier and remote classification level 4. There's no urban center for 1.5 hours from us. Our town is 1,600 people. It's not a city. And in Iowa, our critical access hospital is much like any other of the 1,300 critical access hospitals in this nation. 25 beds, and we do a little bit of everything here. Our county population is only 7,000. However, we've evolved to be more of a regional center in this area. We do 200+ deliveries a year. Procedurally, we do other things, dilation, curettage, C-sections, approximately 25% rate, vasectomies, a few dozen a year, lots of endoscopy, 600 lower, 175 upper. There are some postpartum tubal ligations and other procedures. And because this is a procedural fellowship, I know that's not a lot of procedures, but we feel that we can be effective training with this volume. Our daily inpatient census is about half full, busier than a lot of critical access hospitals in our country. Our surgical volumes are probably closer to about 1,500 for the year. A lot of those would be our scopes. We only have 2 specialties really well represented on a day-to-day basis, and that would be family medicine and general surgery, with general surgery being split a little bit between Dr. Kermode and Jensen. Our ER visits, it's not voluminous. There's only about 8 to 15 per day. And then after that, everybody here is strictly part-time. We have some specialists that come once a month. We have a few weekly people, but the gist of this is not a big place. And a lot of people would look at us and say, we're not a busy place, but I think the whole thing about this is we can train. But having done this for 3 years, lots of challenges come up. I wouldn't call them barriers, I would call them challenges, but these are the challenges. Can you do good training with limited volumes? And what about the trainers? I'm one of them. There's not very many of us. And then how do you train yourself to be a good trainer? And how many learners can you support in an environment like this? What are the logistics? And I think the eyebrow raising that we see from a lot of our colleagues in academic medicine is, what are you guys doing down there? What about academics? So those are our challenges. If Dr. Price is our current fellow, and if Micah Price is currently 1 month into this fellowship, and I'd almost like him to comment on what some of the advantages are of training.
Hello, I'm Dr. Price, Micah Price. So like Dr. Wells was saying, I've been here for about 1 month. I had just finished my residency training up at Mercy One Hospital in Des Moines. And while I was up there, I had the opportunity to come down to Kermode, Iowa about every other Friday in order to work with Dr. Wells in the clinic and in the hospital. So I had a little bit of exposure to what rural medicine, what rural practice is like. But when I came down here to work full time, that was when everything, it it was very different. And it's been a huge, so far it's been a huge help. And I feel like that's how it's going to continue for the rest of this year. After I'm done with this fellowship, I'm going to be going out to Wyoming in a very similar practice setting. And so far this month, I've done hospital medicine, I've worked in the ER, I've worked in the clinic. I've already done probably about 40 different procedures, I feel like. Anything from setting, placing splints to doing C-sections and getting a lot of scopes in. And a lot of this stuff that I'm doing, obviously I have some oversight with those procedures, but a lot of this is just kind of jumping in and training on the fly and being, the way I described it to Dr. Wells earlier was kind of a trial by fire type setting, which for someone like me, that's how I learn, is kind of being let loose and trying to figure things out. And some of the challenges that I've encountered, it's been because where I was trained in residency, I had all the specialties. I didn't have to worry about if the guy had a STEMI, well, my cardiologist is 3 seconds down the hallway. If I had someone that had a stroke, neurology will be there within 10 seconds, it seems like. But being down here, trying to figure out which patients I can keep, which patients I need to ship, and a lot of the patients don't want to leave these rural areas. And so trying to learn how to manage something that normally I would have one of the specialists, all of these things have been, it's been a huge learning curve. And I feel like all of this is gonna, when I end up going to Wyoming, I feel like I'll be able to just hit the ground running out there, and they're not going to be seeing as much of the troubles that Dr. Wells had to help me with out here. But without this fellowship training, I really feel like I would be struggling a whole lot more next year.
So thank you, Micah. So we're going to move on to a little bit more of a lower level view of what we're doing here. So how are we going to do this? First epiphany we had is that we don't have to start from scratch. People in Canada, Australia, New Zealand, probably other places have already done this, have already done a lot of the legwork. It was a godsend when we found what Dr. Iglesias had done up in Canada, and the robustness of the academic portion of his explanation of it, that we could take it to our partners in our particular healthcare situation and all the way up the chain, or shouldn't be up and down, but maybe across the chain, that they could buy into some of this. So that's the thing that's most important about this, is a humble, respectful integration across the entire continuum of care. We're all in different systems. Those systems have us transferring patients between ourselves. This whole thing is built on us having a humble, respectful relationship with everyone involved. And then care that's sensitive to place. People don't want to leave. And in fact, I mean, there have been times down here where somebody's shown up with a prolapsed umbilical cord. They would not have made it up an hour and a half away, or at least that baby wouldn't have made it an hour and a half away, and yet they've had a good outcome because this facility continues to do obstetrical. So what are we going to do, or what are we teaching, and to whom are we going to teach it? Sort of the canary in the mine, and my grandfather actually grew up in Butte, Montana, and so I know what the canary in the mine is from the time I was about 5 years old. The canary dies before the miners die, and then you need to get out of the mine. Well, that's C-section for these small hospitals. If you're going to continue to do full service practice, the canary in the mine is in fact cesarean section. And so that's something that we want to see preserved in all of this. But you can't just do it, and this is something Dr. Iglesias and Dr. Corneliuson have proven. You can't do this if that's all you're going to do. You have to have other procedural things that you're doing so that you keep that operating room crew up to speed, you keep the anesthesia services available, and that you keep your own skills as an operator up to speed. So GI endoscopy tends to be the thing that is most done, at least in the United States at smaller hospitals. That by number volume is the thing that's most common. Ultrasound has become like the stethoscope of our era. Ultrasound and knowing how to use the ultrasound is a procedure. It's not an invasive procedure, but it's a procedure, and it gives you that same sort of coordination and skill set. Vasectomy done in the office, tubal ligation done in the operating room. Those are skills that are necessary in small places, and that's something that you can get your procedural chops on too. Dilation and curettage, that's something that comes up on occasion. Emergency airway management, certainly something we need to do. Abdominal entry, and this is something that I got from and explained it when I was talking to Dr. Batchelor. This is something where you're essentially doing a mini laparotomy every time you put in a Hassan port for a laparoscopy. So that's another skill that can be extrapolated into abdominal access. And there are places, especially up there in Canada, where ESS physicians are being trained to obtain abdominal access to PAC and that sort of thing in trauma. That gets to ATLS and the different forms of ATLS-like courses that are our practice throughout the world. And then critical care medicine. Critical care medicine, the proceduralists will be involved with. The airway portion down here would be done by a nurse anesthetist. Up in Canada would be by GPA. That's something that there's a team approach to, and that's something that we want to make sure that our fellows are experienced. What are the variables? You want to do other procedures appropriate to place. You want to custom fit them. So if we know where our fellows are going and they have some particular need, we can go ahead and train to those procedures also. But I think that first set was the basic set. And then to whom? I mean, it's basically family physicians. Those are the people that are out there. We're in a situation where we have a resident general surgeon here all the time. That's not typically the case any longer in small hospitals in the United States. The general surgery has become sort of a farm team for specialty surgery. So these are things that are going to become more common in the United States as time goes on, and general surgery tends to exit small hospitals, or many of them, and family medicine doctors are going to have to be skilled in procedural medicine. So how long will it take? And this is, the volumes are going to be small, but you need to make sure that you use every case and make sure that it's used well from an educational standpoint. And we do this we review every case after we've done it. We have a form to go over that with the fellow, and then we sort of dissect that out and decide, okay, how do we do? What can we do better next time? And then make sure that you have documentation of that. That's going to inform how you continue on and how you improve. So informative feedback, it's not punitive, it's informative. Every one of the people that shows up here is obviously well vetted. They can do this if we just get them enough procedures and do a good enough job of educating them. Mentorship is super important. I know Joel's a great mentor. That's something that you don't necessarily do intentionally, but the fellows do learn that from just seeing how you respond to crises, how you respond to different things that happen in your practice that they'll have to respond to in the future. And then enough learners, but not too many. One of the nice things about this is that we don't have a bunch of residents running around. I've taught in both major academic centers and now here. When you have too many learners, it dilutes the educational experience for everyone. And so there are ways to sort of get around that, but not having too many learners is a good thing, but you want to have some. So having the residents come down as well as the fellow, there's some synergistic learning that goes on there. The maturity of the learner and teacher, one thing I've learned as a teacher and being involved in medical education for 30 years, the most important thing is having maturity shown by both the learner and the teacher. And I will tell you that in my experience, there's a lot of times where the problem is really the lack of maturity in the teacher. Hopefully that's not a problem here. If it is, that Joel will correct it, if I start acting like an idiot. What we think this will take is approximately a year. And the reason it'll take a year is you'll teach it, but then you have to assess it too. And that assessment confirmation part, that can change. I think teaching it, I think we'll get through teaching most of these things to a level of adequacy probably within 6 or 8 months. But then because these people are going to go to other places, we want to be able to say that we have enough to not only teach it, but also to assess and then confirm that they can do this. And that's, I think, going to take us about a year. It just works out almost perfectly for that. And if we try to increase the number of things we teach, we may endanger that ability to assess and confirm. We may be able to teach it, but we may not be able to confirm it if we get into lower volumes. So what is what is the goal? We want these people to choose the right patient. We want them to choose the right procedure. And this is the part that everybody thinks the only thing we're doing is we're having them perform the procedure correctly. Well, they had to get the first 2 parts right before they got to the 3rd part. And then we want them to document it, all 3 of those portions of it. And then this is the biggest thing, is we want programmatic commitment to closed loop follow-up with our fellows. We want to find out what we've done well, what we've done not so well, and then be able to come back to that and continually refine this. We've already done that as we've looped through this so far. So, and hopefully this will be on a long-term basis successful. I think that's my spiel.
Okay, so one last thing here. So again, we're 3 years into this fellowship, and I think one thing we're convinced is that we're doing exactly what we should be doing here in Corden. And there's 2 concepts to the fellowship in a place like this. And one is that this is an immersion issue. We are taking people from other training environments, larger urban centers, academic centers, and we're placing them in the rural environment, which is unique. This is a rural fellowship. And the other is sequencing. This is a fellowship, which means it is the polishing up phase. It is the last step in training before somebody starts their career. It's not a rural rotation for a medical student to see if we can get them interested in rural medicine. This is a final step, and this fellowship fulfills that mission. So that's if the last slide.